Good evening, everyone. A warm welcome to an enriching session on anticoagulation insights for clinical management, organized by the Times of India in association with Critical Care Division of Biological Limited, one of the leading anticoagulant producers in India. I'm sure most of us might have heard about anticoagulants. For the uninitiated, anticoagulants, commonly known as blood thinners, are medicines that help preventing blood clots that are usually given to people at a high risk of getting clogged to reduce the chances of developing serious conditions such as strokes and heart attack. During this pandemic situation, anticoagulants remain one of the most important pillars of therapy. Also, anticoagulants are widely used in deep vein thrombosis, DVT, dialysis, and even in IVF treatment. To talk more about anticoagulant therapy, its role in cardiovascular treatment, COVID treatments, and various other aspects of anticoagulants, we have experts from the field of medicine joining us today. Before we begin our webinar, I would like to inform our viewers that if you have any queries regarding anticoagulants or any questions for our eminent panel of doctors, please type it on the chat window and we will try to get your queries answered by the doctor. So, without any further delay, let me introduce the eminent panel for the day. We have with us Dr. Sreevatsa Nadig, Chief Interventional Cardiologist, Sahyadri Narayana Multi-Speciality Hospital, Shimoga. We also have Dr. Basavarj, Kuntoji, Consultant Physician, Manipal Hospital, and Consultant Intensivist and Academic HOD, Bhagwan Mahaveer, Jain Hospital, Bangalore. Dr. Pavan, Cardiologist, Associate Professor and Head of Department of Cardiology, KIIMS Bangalore, is also joining us today. We also have Dr. Yogesh Kothari, Senior Interventional Cardiologist and Electrophysiologist, Head of Cardiac Sciences, Bhagwan Mahaveer Jain Hospital, Bangalore. Welcome, doctors, to the webinar.
Thank you.
So let us begin our day with understanding anticoagulants. So, Dr. Sreevatsa Nadig, can you please tell us what are anticoagulants and how are they different from antibiotics like aspirin?
Yeah. Good evening, one and all. I think we are talking about blood thinners, which include anticoagulants, fibrinolytics, and antiplatelets. Everyone is aware of the commonly used drug like aspirin, which basically act on platelets. But anticoagulants act on a different pathway known as a coagulation, and they are more powerful blood thinners compared to antiplatelet agents. And they are used in a different kind of situations, and mechanical valves or prevention of pulmonary thromboembolism or stroke in patients with AF or what is irregular heart rate. In such patients, they are used. Anticoagulants in general are more powerful and slightly more hazardous when it comes to risk of bleeding compared to antiplatelet agents. There are many number of antiplatelets and anticoagulants available. As we go on, I think we will discuss what are the present anticoagulants available in day-to-day practice.
Okay. So, Dr. Pavan Rasalkar, can you please tell us, like, what are the latest advances in anticoagulant medications, and also what are the newer anticoagulants available today?
There has been a paradigm shift, in fact, as far as the newer anticoagulants are concerned. In the last 5 years, we have a lot of newer agents available which have a lot of benefits compared to the oral and the older anticoagulants like the vitamin K antagonists, warfarin, etc. So, as far as the newer agents are concerned, they are referred to as NOACs or DOACs, newer oral anticoagulants or direct-acting oral anticoagulants. Basically, in Indian market, we have three. One is dabigatran, we have apixaban and rivaroxaban. These three are the major players of the newer anticoagulant market. And as far as the question number 2, which you asked me, what are the benefits? There are huge benefits that these anticoagulants have compared to the conventional oral anticoagulants, that is warfarin. First and most important, they do not require any regular monitoring. Like warfarin requires monitoring with PT-INR at least once a month. This requires no monitoring. There is no criteria on the basis of which we need to titrate the dose. Secondly, there is no interaction with food. Warfarin, we all know, has a lot of food interactions. When a patient we put on warfarin, they cannot take green leafy vegetables in a more quantity. Also, there are other drug-to-drug interactions with warfarin. All this are completely nullified by the NOACs. So these are the two major advantages that NOACs have. Of course, they have slight disadvantages also, which we will discuss in the due course of seminar as and when the opportunity arises.
Okay. Just to add on to that, like what are the newer anticoagulants available in the market today?
Yeah, we have three newer oral anticoagulants. One is dabigatran, one is apixaban, and another is rivaroxaban. These are the three newer anticoagulants.
Okay. And Dr. Yogesh Kothari, can you tell us a bit about this anticoagulation card and what is the importance of this card?
Yeah, hi, dear viewers, and hi, Priya. So, anticoagulation, as you know, as already pointed out, it's a double-edged sword. So, at the one end, you have all the benefits of anticoagulation, like prevention of all the thrombotic complications. Maybe it is COVID, maybe it is non-COVID, like DVT, maybe it is in valves, maybe it is in arrhythmia. So, various situations are there, medical conditions are there, where the blood tends to clot, it forms, thickens, and because of those thickening, there are a lot of complications associated with it. So these patients need to be given this to prevent these complications, but at the same time, they are exposed to a risk. So they are exposed to a risk of, say, bleeding. They are exposed, suppose they have an accident, and if it is bleeding, the bleeding will not stop. You might have heard of hemophilia patients, where any patients with hemophilia, they carry a hemophilia card. In similar concept, everybody should have some ID on them saying that they are taking anticoagulation and what anticoagulation they are taking, because the treatment for different anticoagulation to prevent its effect is different. Like dabigatran may have a different molecule to counter its effect. Warfarin may have a different molecule. If it is some other molecule, then the antidote may be separate. So, in an emergency situation, it is a very, very critical information for the people around them or for the treating team to know what anticoagulation the patient is taking. So, it is always worthwhile to carry the information of anticoagulation with you always.
Okay. Thank you, doctor. And right now we are living in a very difficult time, and we are all fighting a very serious pandemic. So my question to Dr. Basavarj is about COVID and anticoagulants. So, like, what are the risks if a patient on anticoagulant get COVID?
Okay, so first of all, with respect to the COVID, there are very few medications which are proven to be having a mortality benefit. Out of which we know one is the steroids, second one is of course the anticoagulants. So anticoagulants has got a very beneficial role in patients who needs admission to the ward as well as to the ICU. The question that what you asked is whether when the patient is already on anticoagulants and if they develop a COVID infection, what to do?
Yeah.
Yes, if the patients are already on anticoagulants, those anticoagulant medications has to be continued even during the COVID infection also, unless they have got an adverse effect like bleeding manifestations or any other concerns where it is contraindicated.
Okay. So just to add on to that, like, what is the role of anticoagulation in critically ill patients?
Okay, so with respect to by and large, in critically ill patients, we get most of the patients who has to stay for a long time. So hence, most of them will require a prophylactic dose of anticoagulation to prevent the thromboembolism phenomenon. And secondly, there are some patients who need a therapeutic dose. That means who have developed either a venous thrombosis or an arterial thrombosis, maybe like a DVT, maybe like a CVT, or maybe an MI or limb ischemia. So these patients will require a higher dose of therapeutic anticoagulation. And in the ICU, we also see patients who are on anticoagulants coming with an adverse effect in terms of bleeding manifestations. So we need to identify such adverse effects and we need to address also. So these are the three kinds of patients wherein we will be seeing the patients on anticoagulants in our critical care ICU.
Okay. Dr. Sreevatsa, Dr. Basavarj was just mentioning about DVT and pulmonary embolism and all that. So I just wanted to know, like, what is the role of these newer anticoagulants in such treatments like thromboembolism or like pulmonary embolism and DVT?
Yeah, I think Dr. Yogesh pointed out a very nice thing. The circulation.
Hello.
Am I audible?
Sreevatsa, we have lost you.
He is audible.
No, it is fine, sir.
Yeah.
Please carry on.
See, there is a delicate balance between clotting and bleeding inside the body. In a normal, healthy person, the blood does not should not clot at any point of time. So, some patients for what are known as hypercoagulable states tend to develop clots inside their leg and thigh veins, which is known as deep venous thrombosis, and that can break up and go into the lungs and can cause sudden death due to clotting in the lungs arteries. This situation is known as pulmonary embolism. In fact, it is not recognized quite often, but they say that it is up to 10 to 20% of patients with pulmonary embolism do not even reach the hospital. So it's a very dangerous and a serious thing. It's also seen in patients who are patients or mechanic following a surgery, orthopedic surgery, or bedridden cancer patients, or patients on these birth pills or oral contraceptive pills. These patients tend to develop these clots and pulmonary embolism. In such patients, the only drug available till recently was warfarin. But as Dr. Pavan pointed out, warfarin has got so many drawbacks and disadvantages, like slow onset of action and there's a lot of drug interactions and all that. The newer anticoagulants, that is dabigatran and rivaroxaban, overcome with that. And now in patients with the DVT and pulmonary embolism also, we can use the dabigatran based on the patient's body weight and renal status. We can modify the dose and we can use both the dabigatran and rivaroxaban or apixaban in such group of patients. The biggest problem is that there is a chance of recurrence, and every time a DVT or a pulmonary embolism recurs, it will lead to more morbidity and mortality. Such events can be prevented by using these anticoagulant medications, including NOACs. In fact, in one of the trials, one of the RELY trial, which was a large trial, dabigatran was shown to be superior to warfarin in preventing re-embolism. So newer anticoagulants are definitely stood the test of all the trials and are here to stay for patients DVT and PE.
Okay. To just add on to that, Dr. Pavan Rasalkar, can you please give us more details about the pros and cons of the new age anticoagulants?
Yeah. Firstly, let's deal with the newer anticoagulants, the three players, that is dabigatran, apixaban, and rivaroxaban. Its advantage list or the pros list is longer, and its disadvantage or cons list is very less. Coming to the major advantages that it has over the older anticoagulants, first and foremost, there is no monitoring required. There is no blood test which you have to do repeatedly to see whether the tablet is working or not. There is no test. We assume, and it is proven, that the drug will make your blood thin in the required range. So first and most important, no repeated blood test. It saves pricking. It saves money as well. Every test will cost you, the PTINR test will cost you at least 250 rupees. That's the first major advantage. Second, no drug-to-drug interaction. Usually patients who are on blood thinners are also on other tablets for whatsoever reason. So the warfarin and acetyltrauma, a lot of interactions. Some other drugs may increase the effect of warfarin. Some other drugs may decrease the effect of warfarin. There is no such things with the newer anticoagulant. Third advantage, this has no food interactions. Like I told you before as well, patients who are on warfarin, they need to have a lesser quantity of green leafy vegetable because that is rich in vitamin K. So if your weekly intake of green leafy vegetable varies, the anticoagulation level, the blood thinning level varies. It can go down, it can go up. If the blood thinning level is less, there is a risk of clot. If the blood becomes more thin, there is a risk of bleed. This is something we refer as a narrow therapeutic index. The INR or the blood test which you are talking should be maintained within 2 to 3 only. If it goes less than that, there is clotting. If it goes more than that, there is bleeding. Warfarin, in fact, there have been numerous studies, nationally as well as internationally, which have shown that less than 50% of the patients who are on vitamin K antagonists, that's warfarin, are in the target INR. Most of the times, they are either on the lower side or the higher side, and both the sides, the risk is there. So these are the major advantages that the newer anticoagulants have. Coming to disadvantages, there are two main disadvantages. Coming to the Indian scenario, the most important disadvantage is the cost. These drugs are way costlier compared to warfarin, which is like a 1 or 2 rupees tablet. But although I would go ahead and want to tell you that the cost difference eventually is not like a heaven and hell difference, because with warfarin you have to do blood tests at least once a month. In people whose INR is labile or very fluctuating, probably every weekly INR is required. So that adds up 500 to 1,000 rupees per month, which is not required with the newer anticoagulants. But yes, in a resource limited country like India, cost plays a major factor in when we prescribe drugs to the patient. This is the first major disadvantage, that it is costlier compared to the older ones. Second major disadvantage is availability of an antidote. Assume the worst case scenario, patient is on blood thinner, lands up in an accident, he is bleeding profusely. We need something to stop the bleeding immediately, to make the blood more thick, back to the normal. Vitamin K antagonists have an antidote, that is vitamin K. The newer drugs, dabigatran has an antidote which is called as idraxazumab. Again, the problem with that is it is not easily procurable. Vitamin K is available everywhere. Go to any chemist shop, you have a vitamin K. Idraxazumab is not available freely and it is very costly. It costs 1.5 lakhs. Not everyone can afford that. So this is the first major disadvantage of newer anticoagulants. Reversal of anticoagulation is difficult. These are two, in fact. More cost and reverse of anticoagulation. And rivaroxaban and apixaban, as of now, do not have the antidote in Indian market, which is endoxanate alpha. So that's about the pros and cons of the anticoagulants. I think Sreevatsa sir wants to add on something.
I think one more thing where warfarin still has a role in is in mechanical processes. That is, patients who receive a metal valve for valve replacement. In such group of patients, warfarin is still the gold standard drug, and newer anticoagulants cannot be used in such situations. And even in patients with pregnancy or end-stage renal disease, even in such group of patients, still I think warfarin still has some role, especially in rural India, where in mid trimester of pregnancy we still use warfarin. And one more drawback of the newer anticoagulants is that we cannot measure the efficacy of the drug. Like in warfarin, we can measure what is known as the PTINR, whereas whether this newer anticoagulants, what is their efficacy, whether attain the therapeutic effect. There are tests like thrombin time and all that available, but it is not available in every place. This is one of the points. Maybe in such situations where NOACs are not always the answer for warfarin. Warfarin has still some role in certain situations.
Okay.
That was very well put. Third disadvantages of the NOACs. We still have a certain subset of patients wherein warfarin still remains the gold standard. Although, as far as the indications concerned, almost 90% of the indications we can use NOACs. Like sir rightly mentioned, these are the very specific things wherein we still give warfarin.
Okay.
Gastric side effects are another very important side effects of NOACs.
Yeah, Dr. Yogesh, you want to add something to it?
Yeah, some of the NOACs have a lot of gastric side effects, especially some people develop gastric ulcers, sometimes they develop GI bleeds. So that is something that we need to monitor with all anticoagulants, but slightly more with NOACs. So we need to regularly not only monitor the PTINR, but we need to monitor the hemoglobin, other parameters, 2 local blood once in 6 months or once in a year, so that we pick up bleeding early and treat them early so that they don't land up with severe complications.
Okay. In fact, that is my next question to Dr. Yogesh. Like, how do we monitor, and how frequently do we monitor anticoagulation?
So for warfarin, there is something called as TTR, that is time to therapeutic range. So what we mean is that, patients who are taking this warfarin, they need to ideally be monitored very, very strictly. In certain conditions, we even monitor them when they have some artificial prosthesis, like as Dr. Sreevatsa said, like if they have a valve, if they have a LVAD, left ventricular assist device, if they have bad heart failure, and if they have ongoing DVT. So it's such conditions, if we are using warfarin, we need to monitor them at least once in 2 weeks minimum, and sometimes in some conditions we may even monitor them weekly, especially if they have a labile INR. Once they have 2 to 3 values which are in the therapeutic range, then we can extend and slightly liberalize to 3 weekly or 4 weekly. But at least in the initial part, it is very important. And whenever there is a change, like, if they get a cough, cold, or whenever they get some other medication to be added, if they're adding some other additional medication, immediately the INR should be checked. So this is what we do for monitoring as far as the warfarin is concerned. When it comes to newer anticoagulants, the requirement of monitoring is not required, because these drugs, what has happened is they have been studied in large clinical trials in very heterogeneous population. It is not just Indian population or African population or American population. So the entire heterogeneous populations have been taken, and they have done what is called as a dose finding study. And based on the dose finding studies, 2 doses have been recommended for all of these NOACs. So for when it comes to dabigatran, it is 110, 150, and occasional 75 milligram. When it comes to apixaban, 2.5 and 5, and when it comes to rivaroxaban, you have 15 and 20. Sometimes we do use 10. So this kind of, based on these dose finding studies, we know what is their therapeutic range. And most of the time, most patients fall in that therapeutic range, is what we assume based on the trial data. Nevertheless, in your patient, if you want to specifically look for what is their anticoagulation effect, we can do certain tests like factor 10 ASA, thrombin time, and various other thromboplastin times, and other tests are available, but they are not, as Sreevatsa said, they are not routinely available, and not routinely available at all centers. So this is how we monitor the patients. In addition to monitoring of the blood thinner effect, we need to have some safety monitoring. As I already just mentioned, you need to monitor their hemoglobin once in 6 months. You need to monitor what is called as a stool occult blood, where they may be losing blood silently inside because of some small ulcers, and that stool occult blood, we do it at least once in a year and things like that. And of course, we need to regularly monitor the creatinine clearance, because the change in creatinine clearance will be associated with the change in the dose. Because if the creatinine clearance is going down, the dose that you may be giving is more and may be accumulating and causing toxic side effects. So this is the third point. And fourth point is in an emergency situation, that I think will come at a later date, and we'll discuss at that point of time.
Okay. And my question to Dr. Basavarj is, like, when you think about like COVID-19 and this anticoagulants, like one term that I came across was coagulopathy. So what exactly is this COVID-19 associated coagulopathy? And how is it different from DIC, or designated intravascular coagulation?
Yeah, so when we know any infection can lead on to coagulopathy and DIC, but COVID-19 has got a specifically a different kind of coagulopathy. Generally, as per the International Society of Thrombosis and Hemostasis, we go into 5 criteria when we diagnose DIC. So I'll go one by one. Number one is the thrombocytopenia, that having low platelets, especially in COVID-19. Yes, majority of them have got a low platelet, but the characteristic is that generally it is not severe thrombocytopenia. So generally it is not less than 1 lakh, and very rarely it is less than 50,000. The second point with respect to the coagulopathy or DIC in COVID-19 is the derangement of the coagulation factor, that is PT-APTT, is very minimal in COVID-19, whereas in other infections, it generally the INR and APTT is very much prolonged. And the third one is, yes, the D dimer is elevated in COVID-19 and it is elevated in other infections also. And the fourth one is the fibrinogen level. So fibrinogen level again is decreased in DIC conditions, and it happens even in COVID also. And the fifth one is microangiopathy. When we do the peripheral smear, it is more common in any other infection, whereas in COVID-19, these microangiopathy is not seen. So these are the differences and characteristic of coagulopathy in COVID-19. And generally, in most of the other patients, wherever there is a coagulopathy is there or DIC is there, they land up with bleeding. And the bleeding in COVID-19 infection is very rare, but however, we do see in rare patients also. So these are the coagulopathy characteristic of COVID-19 infection, specifically what I could say.
Okay. Just to add to that, like as you said, like there could be like bleeding in COVID-19 patients. Is it like only for like critically ill patients, or is there any particular criteria?
Yeah, so COVID-19 patients generally have got less bleeding compared to any other infections who land up with a DIC. But in COVID-19 patients, whoever has got into DIC, that means whoever has got a deranged coagulation, whoever platelets have gone very low, in them it also attributes to mortality. So patients who have died has got severe DIC pictures. So patients who have died also have got a severe DIC picture even in COVID-19 infection also.
Oh, okay. And another major role of anticoagulants is in cardiovascular treatment. So I would like to know from Dr. Pavan, like what is the current role of anticoagulants in cardiovascular medicine?
Yeah, a very apt question. As far as the role of anticoagulants, especially the oral anticoagulants, are concerned, there are certain conditions in cardiovascular medicine wherein we use. A couple of things I've already covered, that is the clotting in the lower limb veins or the deep venous thrombosis. Then there is clotting in the brain veins, that is CVD. And then we have pulmonary thromboembolisms, that's the clotting in the veins of the lung. So these are the three conditions which are commonly wherein anticoagulation is used. Coming to the fourth condition, which you have not yet touched as of now, is something called as atrial fibrillation. So atrial fibrillation basically means the heartbeat is not very regular. The normal heart rhythm should be regular. It should come at a very regular interval. What happens in atrial fibrillation, which is in fact the most common arrhythmia world over, is that the heart beats in a very irregular way. And because of this, there is a tendency to form clots in the upper chamber as well as the appendages of the upper chambers of the heart. And this clot can go anywhere into the body, and usually it goes from the heart to the brain, leading to stroke. So atrial fibrillation is one of the very specific indications in cardiology wherein anticoagulation is required. So these are the very common things which are wherein anticoagulation is required. And one rare condition which you don't encounter very often is something called as clots in the heart, or the left ventricular clot, LV clot. This usually happens when the heart pump goes very low, not able to pump properly because of the blood stasis inside the ventricles or the lower chambers of the heart, the clot forms. So these are the indications wherein anticoagulation are required. And in almost all these indications, NOACs can be used except LV clot, wherein the trials are still going on. We do not have conclusive data or the guidelines wherein we can use the newer anticoagulants in LV clot. But in rest all, whether it is DVT, CVT, pulmonary thromboembolism, or atrial fibrillation, anticoagulations, the newer ones have a very good one.
Newer research is also there. I think just to add to what Dr. Pavan has said, that even in coronary artery disease, low dose anticoagulation now is gaining a lot of ground. We give rivaroxaban 2.5 milligram. I think more and more cardiologists are now using this, at least in some high risk subsets, what we call as a very low dose of anticoagulation. A normal anticoagulation dose is 20 milligram of rivaroxaban, whereas for this coronary artery disease, we use 2.5 milligram along with a single antiplatelet.
Triple antithrombotic therapy.
Yeah. So that is something, it is an emerging indication that is happening. And I think a lot of trials in that direction are happening in that. I think we'll have more on the data on that probably in the coming times.
Okay. And as we discuss about heart diseases, my question to Dr. Sreevatsa is, can a person with a prosthetic heart valve use novel oral anticoagulants, which are popularly known as NOAC? And are there any reversal agents available for NOAC?
I think there are two different questions that you addressed. One is whether NOACs can be used in mechanical processes.
Yes.
So warfarin has been there since 1940s and 50s. Initially, it was described as a rodenticide. It was used to kill mouse, and later they found out that it is a blood thinner agent too. And when President Nixon was saved by using warfarin in a heart attack. So it is there since like 60, 70 years, and there is extensive data on the safety and efficacy of warfarin. And it is a good old drug for management of mechanical thrombosis. But when the NOACs came in, the warfarin is a very painful drug. As many times it has been pointed out, you need to keep taking INRs and all that. You cannot eat the vegetables of your choice. It's very easy to say, but most of Indians are vegetarians. And if you ask them not to eat green leafy vegetables, they're left with very few things to eat. And they have to take a tablet at specified time, that is 6 p.m., and not to eat anything after that. It's very, very difficult. Even a simple painkiller like a brufen can cause massive bleeding, or a simple antibiotic like quinolones, like levofloxacin, can cause derange in INR. So it's a very messy drug, warfarin. So when NOACs came into picture with the Relay trial in 2009, there was a lot of hope that warfarin would go away and in patient mechanical process will be a boon. But many trials were conducted and NOACs failed when compared to warfarin. So it's a clear no-no. They are not indicated in patients with mechanical processes, neither in patients with rheumatic heart disease, metastenosis. So these are two clear contraindication where NOACs cannot be used. Only warfarin is to be used. I think that answers the first part of the question. We will address the other question was whether there are
Reversal agents available for
reversal agents are available for NOACs, but not commonly available. That is the problem, especially except in metros. Only for dabigatran it's approved by US FDA, idarucimab, but otherwise the factor 10 inhibitors like rivaroxaban and antipixaban, adexinate alpha is there, but it is not available as of today. So availability of antidotes is a difficult thing. What we can use is prothrombin concentrates can be used. If it is not available, that's one alternative that can be used for dabigatran toxicity. But rivaroxaban and apixaban still do not have specific antidote widely available as far as I know in India.
Okay. And my question to Dr. Yogesh is, like, if there is any emergency, like a surgery for a patient on anticoagulation, what is the way forward? I mean, like, how is it done?
So it has to be differentiated into very, very urgent and urgent. And obviously, if it is very, very urgent, patient is having space of bleed and bleed in the brain and such things where an emergent evacuation is required. I think there you may not have much choice. You need to give them fresh frozen plasma, cryoprecipitates, and go ahead with the surgery and immediately arrange for an antidote, as idarucimab is one of the antidotes available. At least we are in metros, so I think metros at about 20 minutes to 30 minutes notice, the people are able to arrange the idarucimab. As I'm sure I agree with Sreevatsa that non-metro city, this may be a futile task, and it may not be so easily available, especially more and more smaller towns. So usage of antidote, proper precautions, cauterize the bleeder. So the surgeons, they go out of their way in these patients. They make sure that there are no bleeders. So they use extensive cautery so that the amount of bleeding spots are minimized, and putting drains where you see a potential bleed. So these are all the simple things that we do when we have to do an emergency surgery. And if that surgery can be postponed by 12 to 24 hours, then that becomes a more ideal situation, because all of these NOACs, one good advantage is they are short acting. So you miss 2 to 3 doses, the anticoagulation effect is already coming down. So that advantage is there. So if time can be bought, then we buy that time, at least 12 to 24 hours, and that time can be used for procuring the antidote, giving cryostates, giving fresh frozen plasmas, and then do the surgery in a more safer situation. But it is not always true. There may be an extensive road traffic accident where you may not have time. The minutes or seconds may be important. In such situation, proper hemostatic measures are all that you can take care.
Okay.
In the meantime of arranging the required antidote.
Just to add on what Dr. Yogesh and previous discussion, the other issues, what we have commonly practically seen is patients who have got NOACs and started bleeding and have come to the ICU. Majority of them we were unable to arrest the bleeding, unable to save them. So that is the main disadvantage practically, which all of us know. Whereas if they are on other anticoagulants, somehow we will be able to save them. But patients who are on NOMAX and have come into the critical care, have got bleeding, have become hypotensive, and it is very rare to bring them back, is what we all agree, I think.
Okay.
Yeah, one point I would like to add here is patients with NOACs and atrial fibrillation, they still have some propensity to develop stroke. So ischemic stroke. A patient who is already on anticoagulation develops a ischemic stroke, comes in the window period. In such a situation, this new Praxpine or the idarucimab can be used to reverse the effect of dabigatran, and then we can thrombolize. That cases have been reported, I think, in Indian Heart Journal and many this one. That is one more situation where antidotes to this dabigatran can be used. It's an emergency situations.
Okay.
That is talking of stroke thrombolysis, which is a very important therapy for acute strokes. So I think Times of India should take an initiative on stroke. I think it's very important. Now heart attacks at least come to the hospital within about 6 to 8 hours, but strokes do not reach the hospital on time, and a lot of limb and movements are wasted because of delayed presentation. I think that's.
Yeah. And Dr. Basavarj, talking about COVID infections, what are the various thromboembolic complications seen in COVID patients, and post the discharge also, are there any complications?
So I think these anticoagulants are used in wherever there is a thromboembolic phenomenon, and we have seen in COVID-19 all thromboembolic phenomenon we have seen, especially patients who are admitted to the ward or to the ICU. So venous thromboembolism, it could be a deep vein thrombosis, or it could be a pulmonary embolism, or it could be a intestinal venous thrombosis causing the gut ischemia, or it could be an arterial ischemia. They can present with stroke, or they can present with limb ischemia, or they can present with the heart attack. And these thromboembolism phenomenon, especially during the admissions, are found more. So especially in the first wave, and as and when we know that these are available, so we all have started using the thromboprophylaxis also in such patients. Uh, the other problem is whenever the patients have improved and become all right, and the post discharge also. So these patients again come back, and few of the patients have landed up having a heart attack, having an MI. Few of the patients have developed arterial limb ischemia, wherein the leg has to be amputated, and few of the patients also have landed up with a stroke. So these are the post discharge complications also what is being seen. The question is how to prevent by use of oral anticoagulants. Initially, we all started using prophylactic dose of anticoagulant, and there the also came whether we can start using the therapeutic dose. The evidence as it stands based on various studies says that therapeutic anticoagulation is good enough for the ICU patients. With respect to patients who are admitted to the ward, it's an interesting study by REMAP-CAP says that in them you can use a therapeutic dose, but however the data is still not published. But we all do a prophylactic dose of anticoagulants. The third question comes: patients who are on outpatient basis treatment, patients who are at home care treatment, whether the medications is going to help. In general, by and large, the medications or the thromboembolic phenomenon in these outpatient basis patients are less. Hence, in these individuals, generally we do not give anticoagulants unless there was a risk of thromboembolism, like maybe whether they got a recent surgery, whether they are bedbound. In them, yes, we may advise giving them the oral anticoagulants. So the overall thromboembolism phenomenon, what we have seen, any other condition, all the thromboembolism phenomenon we are seeing in COVID-19 infection.
Okay. Moving to the next phase of our discussion, I would like to ask Dr. Sreevatsa. Sreevatsa, what are the serious drug-to-drug interactions, and to avoid it, what can be done, and what are the drugs that needs to be avoided normally during an anticoagulant therapy?
Yeah, as I told earlier, warfarin is a very messy drug. It has got a lot of drug interactions, even with many commonly consumed food which are part of Indian diet. Common drugs like painkillers, antibiotics like erythromycin, anti-fungals like ketoconazole, or even antacids like omeprazole, or what drug antiarrhythmics like amiodarone. So there are a lot of drugs which can interfere with the metabolism of warfarin. In India, we don't get cardiologists everywhere, and say a patient with coming from a remote village having a mechanical processes develops a cough or a cold or some body ache, and he goes to the chemist and buys a painkiller, and next day he ends up in the emergency room with a massive intracranial bleed, or it takes antibiotic and comes with a struck wall. So there are a lot of drug interactions. Even the common things that we should remember is painkillers are a strict no NSAIDs, what are known as, they should be strictly avoided in this group of patients. And antibiotics, we have to be extremely careful, and antacids also. We even advise them about foods to avoid green leafy vegetables and foods which are rich in vitamin K. And even when we look at the TV editorials, we might patients are tempted to use multivitamins. Even multivitamins are cause drug interactions with warfarin. So there are a lot of drug interactions, and patients need to be educated as to avoid using such drugs. Consult cardiologists or their physicians before taking any of these drugs.
Okay.
One
Actually,
point
right.
I would like
Sorry?
to add, Priya, here. One point I wanted to add.
Please.
And as Dr. Sreevatsa said, and what we can tell our viewers who are going to be little educated is on the web, there are whatever Dr. Sreevatsa has just mentioned, all those data like drug interaction data is available on the web. And patients who are educated and can look up on the thing. So there's an anticoagulation site available, and in that site, the list of the drugs. So whenever they are prescribed with any drug, they can check on the website whether it interacts with warfarin. So warfarin interaction list is available on the web freely, and it can be downloaded by people, educated people who are taking warfarin. We also, in our practice, routinely give that list, but it can never be comprehensive because newer and newer drugs keep getting added. So that's some message that can go to the viewers to have a list handy of interactions with warfarin. The list is readily available on the internet.
Okay. And it can be like kind of used by everyone who are.
Yeah. It has the molecule name. So whenever they are prescribed with some molecule, like Dr. Sreevatsa said, levofloxacin, or say any antihistamine, anything. So they can look at that specific molecule and they can do a check. So warfarin check it is called as. So they can do that.
Okay, 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 okay. That's very informative to the viewers actually. Coming back to Dr. Basavarj, I would like to know, what are the common or what are the various anticoagulant drugs prescribed for COVID-19 patients? Hello?
I think I did not hear you the last sentence.
What are the various anticoagulant drugs prescribed in COVID-19?
Yeah, so patients who generally we call it as mild, I mean, COVID-19, we call it as mild, moderate, severe. Mild are the one who we try to manage at home. So most of them, the risk of developing a venous thromboembolism is very less. So most of them are not prescribed generally with any oral anticoagulants. The second one comes the moderate COVID-19 infection, wherein they need to get admitted to the hospital, but not to the ICU. So in them, yes, generally we prescribe either heparin or we prescribe a low molecular weight heparin. So in generally, the admitted patients, we want to give them injectable drugs. When the patient is in severe condition, generally they get admitted to the ICU. So in them, again, the unfractionated heparin or the low molecular weight heparin is what is being used even in COVID-19 infection. But when we discharge them, when these patients gets better, when we discharge, and wherever the thromboembolic risk is high, in them, yes, we do add these oral anticoagulants, maybe ranging from a month, sometimes 2 months, sometimes up to 3 months is being added for the patients who have got risk. So these are the either the low molecular weight heparin or the heparin in admitted patients, and oral anticoagulants who are post discharge. In them also we use these medications.
Okay, okay, okay. Dr. Yogesh, Dr. Basavaraj just mentioned about a couple of anticoagulants for the COVID-19 patients. So I would like to know from you, can you please share a few more details about oral and injectable anticoagulants?
So I think we already discussed initially that anticoagulants are different from antiplatelets. So that is one very important distinction that we need to make. That antiplatelets are a different molecule where they affect the platelets, and anticoagulation, as Pavan said, affects the clotting factor. So for anticoagulation, we have 3 or 4 different classes of molecules. Oral are divided into vitamin K dependent and newer anticoagulants. That is, vitamin K dependent is like warfarin or acetrom. These are the 2 commonly used molecules in India. And newer anticoagulants, already we have discussed today. The entire webinar has been around the newer anticoagulants and already listed by Pavan. Coming to injectable anticoagulation. Injectable anticoagulants are very, very commonly used and has got a very, very wide range of applications. It may be a heart condition, it may be a post-op condition, it may be a pre-op condition, it may be in pregnancy where they have preeclampsia, DIC, or it can be so many other varied medical conditions. More than 100 or more of those conditions are there where we have to use an injectable anticoagulation, including all the heart conditions like pulmonary embolisms, heart attacks, atrial fibrillations. Pre-operatively, before a surgery, we use low molecular weight heparin. Post-operatively, we use low molecular weight heparin. So they are divided into heparin-like molecules, which include enoxaparin, fraxiparin, and dalteparin. Then we have another group of molecule which is called as fondaparinux. So this fondaparinux is a replacement for heparin. And then we have a third class of molecules which are called as direct thrombin inhibitors, and they are basically divalurudin and agratrobin and various such molecules are available. So different classes of molecules are there, and in those classes of molecules we have different choices that we can use, and it varies from condition to condition. And the reason why you need heparin alternatives is because what we call as heparin induced thrombocytopenia. So you know about all these ECMO and all. I think it's become very famous post Jayalalitha, post COVID. ECMO has become one of the famous therapies in medicine, and patients who are on ECMO lot of platelets get damaged in the ECMO circuit. Plus, heparin also damages the platelets. And in such patients, we cannot use heparin. So in such patients, we use the direct inhibitors like bivalirudin or agratrobam in such patients. And when we discharge patients, we may use fondaparinux because it's just once a day. It gives a full therapeutic effect with just once a day dose. Whereas enoxaparin, we need to use twice a day. Heparins, we have to use 4 times a day. So various flexibilities, various benefits are there. Heparin can be given as infusion. These cannot be given as infusion. And so many other, even when we do any cardiac procedure, we have to use heparin. Whether it is angioplasty, whether we do any other procedure like a valve procedure or anything. And when we do a bypass surgery, once the patient goes on the pump, patient has to be heparinized. So there are very, very wide clinical applications for these molecules and wide variety of molecules available.
Okay.
Basically into 4 different groups.
Okay. Actually, in the beginning of our session, we had mentioned about atrial fibrillation. And my question to Dr. Pavan is, what is the role of anticoagulants in it? And is there an increasing need of anticoagulant therapy in prevention of atrial fibrillation?
Yeah. So atrial fibrillation, basically, I mentioned before, is an irregular heartbeat wherein there is propensity to form blood clots in the upper chambers of the heart, which may dislodge and go to the brain most commonly and cause stroke and all. There's a huge role of anticoagulants in prevention of stroke. Actually, there's no role of anticoagulant in preventing atrial fibrillation. They're not used to prevent atrial fibrillation. They are used to prevent the after effects of atrial fibrillation due to clots. That is, strokes in particular, ischemic stroke. That's where the role of anticoagulants come in. And yes, so which are the patients in which anticoagulants are given, or any patients with atrial fibrillation do we give anticoagulation? So that's the most important therapeutic decision that needs to be made when we have a patient of atrial fibrillation. We have a very set rules for this, in whom to be given and what anticoagulation to be given, whether just we can give an antiplatelet or anticoagulant, etc. There are various scores available to calculate the risk of the patient of atrial fibrillation having stroke. The most common one used is called as the CHATS-VAS2 score, wherein the different criteria like hypertension, diabetes, old stroke, heart failure, female gender, age above 75 years of age. We look at all these criteria, we jot down the score. If the score is 0, we can use 0 or 1, basically antiplatelet agents are used. If it is 2 or above, usually we go with anticoagulants, because if 2 or 3 and above, that's wherein the risk of stroke is high, and hence a proper blood thinning is required, and we use anticoagulants. And this newer anticoagulants all can be used in prevention of stroke in atrial fibrillation. There is enough data. I mean, there are truckloads of data which we have currently, very good quality trials which shows that anticoagulation really helps in prevention of strokes in atrial fibrillation. Nadig sir also mentioned that there may be a subset of patients who may eventually have stroke even on anticoagulation. But mostly these are the patients again who are on the older anticoagulations like warfarin, wherein the PTINR is not in range. With the newer anticoagulants, the risk is, patient having stroke is very less, although not 0%. And yes, if the patient has a stroke, even on anticoagulation, there are therapeutic modalities available to intervene in stroke, like we have the stroke thrombolysis, and more importantly in that we have something called as mechanical thrombectomy in stroke, wherein a small wire is put into the brain vessel and directly the clot is sucked out. These are all the advances which we have in stroke management currently. So yes, there's a definite role of anticoagulation in stroke.
Okay. And we are almost reaching the last couple of minutes of our webinar, and we are open for questions from our viewers also. So we'll be getting questions from our viewers. And I have a generic question. So any of you can just take it like. What are the vital parameters to be monitored for patients on anticoagulants?
Yeah, Priya, hi.
Yeah.
So I think on the monitoring front, I think we have discussed some of them. The most important is the efficacy and the safety. So I think we had discussed that initially, and those are the things that we need to monitor. And obviously, we need to monitor the hemoglobin and other parameters, which we had already mentioned, PTINR and other parameters. Bleeding time, clotting time, occasionally we do, but not having a direct and definitive role. Secondly, adding to what Dr. Pavan discussed about stroke prevention and atrial fibrillation, as Pavan said, so we look at what is called as a CHADS score and then decide on the need for anticoagulation. But unfortunately, there are a lot of patients in whom, though they are eligible for anticoagulation, but because they may also have, the same patient may also have a risk of bleeding because of what we call as a very high Hasbled score. So in such situation, because we may not be able to give anticoagulation, we have to look at alternative therapies in them. So there are a lot of mechanical alternative therapies available. One is called as a left atrial appendage closure. So what we do is the place where the blood clot forms in atrial fibrillation, we put a small mechanical device there, an umbrella-like device, and that device plugs that area, a blind spot inside the heart where blood clots form, so that the blood clot formation is prevented and hence indirectly prevents the stroke. This is called as stroke prevention devices. There are also some percutaneous stitches available, like lariat stitch and other stitches are available. But the more popular ones is basically the left atrial appendage closure device. Secondly, in patients with DVT, we use stockings. In prevention of DVT, we use mechanical devices, which also prevents deep vein thrombosis. Most of the ICUs, I think Dr. Basavarj will agree, have these mechanical devices, suction kind of devices, which applies pressure on the calf veins. Basically, why in ICU the blood clots formation happen is because in ICU we are constantly lying down without moving our limbs, and the blood tends to stagnate there. And based on the Virchow trial, one of the most important criteria for blood clot formation is a stagnation. And that stagnation leads to blood clot formation. So when we use these mechanical pumps, that blood clot stagnation is prevented by actively pumping the blood back to the heart from the leg in a non-ambulant patient. So these are kind of mechanical devices also available. So they should not be forgotten.
Okay. My question to Dr. Sreevatsa is about COVID vaccination. There are some discussions like COVID vaccination is kind of associated with high risk of thrombosis and things like that. So is it true, or is there any correlation like that?
I wouldn't say it is also with high risk. There are some isolated case reports like cerebral thrombosis or that is heart attacks and mesenteric infarction following COVID vaccinations. Um, the incidence is extremely rare to call it high. There are already hesitancy in people's mind to take vaccination in our country and across the globe. If you look at the risk benefit ratio, the chances of dying from COVID is much higher compared to dying from vaccination. It's extremely rare, maybe 1 in 1 million. So I think we cannot say high incidence, but yes, there are some documented reports following certain COVID vaccines, not all of them, that it can lead to higher risk of arterial and venous thrombosis. And even I had, I think, one or two patients. I cannot directly attribute it to vaccination per se, but if you look at the time interval following vaccination, 3 to 4 days later, the patient developed heart attack and he needed angioplasty without any conventional risk factors like smoking, diabetes, and all that. And I heard from my colleagues, my friends also, that there is slightly higher risk, but the risk is much higher of if a person is not vaccinated. Thrombosis can occur because of COVID infection also, as Dr. Basuraj sir has already pointed out. I have had a patient with 21 years who is otherwise totally healthy, had COVID infection, and because of the COVID infection, he had a massive heart attack and his heart pumping went down. So there are certain isolated case reports of arterial and venous thrombosis following COVID vaccination, but that should not prevent one from, that should not be a hindrance. to take COVID vaccine. I don't know what Dr. Yogesh and Dr. Pavan and Dr. Basavarj will say about this.
Okay, maybe I will add on something. It is called as vaccine-induced thrombosis and thrombocytopenia, or also it is called as thrombotic thrombocytopenic syndrome, and it is mainly because of the platelet factor 4 against the COVID vaccine what we develops. Almost similar like that of the hit what we see, but definitely it is not a hit. The incidence, as Dr. Sreevatsa was mentioning, is very low, and it is found that what we all worried is about AstraZeneca. So when I went to the available evidence, 1 in 26,000 patients can have this TTS, whereas in Johnson and Johnson, maybe 1 in 5 lakh patients can have this TTS, and it is very rare in mRNA vaccine, mainly the Moderna and Pfizer vaccine. So how to suspect is the patients who have received the COVID vaccine, if they present within 14 days, or if they present up to 30 days, the thrombotic complications, as we all aware, or when they have done a blood test, if they have a low platelets. So that's when we need to suspect. But how do you diagnose? Yes, we need to measure this, as I told, platelet factor 4, but not definitely the hit antibodies. And if they have developed the thrombocytopenia and thrombotic complications, what is the treatment available is, in spite of having them a thrombocytopenia, we need to give them the full therapeutic dose of anticoagulation. And few of the patients IVIG also is being used, and some of the patients platelet transfusion and fibrinogen also can be used in these TTS patients. Is there any way that we can prevent somebody can land up with TTS? As of now, we do not have any way, or we cannot predict anybody who can develop into a TTS. But as the incidents are rare, and as Dr. Sreevatsa mentioned, the risk versus benefit. So we need to advise everybody to take into the COVID. COVID vaccine is what I could say.
Okay. So before we wind up, one last question I would like to ask is, what are the things a patient on anticoagulant medicine must take care? Are there any tips or suggestions or advice that you would like to?
Yeah. Basically, be aware why you are taking the medicine. That is one important thing. What is the indication? Be aware of what are the side effects, and always carry information. Your immediate relatives should know what exact molecule you are taking, and carry an ID on that. And also, your family doctor should be aware of this. And also, regular monitoring is the most important thing in anticoagulation. Most of the time in India, especially, we have seen our heart patients, they come from rural background, and they think that once the surgery is done, everything is fine, and they land up after 1 year, 2 year with a very major complication, be it a struck valve or be it a hemorrhage in the brain. So be aware, regular monitoring. I think that is the key in anticoagulation.
Okay. Anybody want to add anything to it?
Yeah, anticoagulation is like a boon for cardiac and this one patients. If they take it properly, I think it can prolong their life and give a very happy and healthy life. But it's a double-edged sword. If appropriate care is not taken, and as Dr. Yogesh pointed out, if appropriate drug interactions and food interactions and monitoring is not done, then it could be extremely dangerous and sometimes lethal also. So I think that is a very important point that I think our viewers should be told about from this forum.
Okay, thank you. With that, we come to a close of this very enlightening and very enriching webinar. Thank you, Dr. Srivastava, Dr. Basavarj, Dr. Pavan, and Dr. Yogesh for your valuable time and insights. Thank you so much. Thank you, everyone.
Thank you, and thanks to all the viewers who are watching this program also, and to Biological E also, who have made this program really possible. Thank you very much.
Thank you.
Thank you.
Thank you.